Yeah. Can you see my slides?
Yeah.
Okay. So thank you so much, Vaidehi, for these introduction. Thank you, Rima. And I'm going to be talking about something slightly different, which is called personalized glycemic response. Just to give you a little bit of introduction. So we are in an era of personalized nutrition. So personalized nutrition approaches provide healthy eating advice tailored to nutritional needs of individual. We all know that. And although there is no one definition for personalized nutrition, advice has been typically based on individuals' behavior, biological characteristic, and their interaction. The objective of personalized nutrition is to improve dietary habits for prevention and treatment of chronic diseases, which ultimately contributes to improvement in public health. So when we talk about personalized nutrition, it is not about giving a diet chart. It is actually about creating a better eating habit that suits that person. So now we know that although there are standard guidelines available for almost all diseases, and despite of having both treatment and lifestyle guidelines, we find that number of people with uncontrolled problem, for example, number of people with uncontrolled HbA1cs are much higher across the world. And the reason for that is the guidelines are very standard. They are not tailored individually. And if they get tailored individually, probably it will help people to lead their life better, because these are not problems for 15 days, 1 month, but these are lifelong problems. So another definition can be use of individual specific information. And I think this term is very important, individual specific information found on evidence-based science to promote dietary behavior change that may result in measurable health benefit. So this is again a very good paper which got published recently about personalized intervention, where they have said that it is now well acknowledged that in order to gain full benefit of dietary regime, it is essential to take into account individual responses. And this is true for all problems, but more specifically for diabetes, and that is what I am going to be alluding to. So what is patient-centered care? Patient-centered care is actually the cornerstone of dietetic practice. It is a key tenet underlying this approach is individualization of guidance based on patients' specific needs. And in broad sense, it is not about treating the disease. It is about treating the patient. So maybe, the basic guidelines may advise something, but ultimately we see that it is the patient's different response to the same treatment that changes, and therefore it is very important to treat that patient and not the disease. So there are numerous apps available, numerous programs, platforms, and plans are now aimed at delivering personalized experience for user base on profiling of an individual's demographic, genotype, nutritional intake, status, anthropometrics, so on and so forth. Now, what are the novel concepts in management of diabetes? So we all know glycated hemoglobin, or HbA1c as it is called as, is gold standard for assessment of long-term glycemic control and response to treatment in patients with diabetes. But very important to understand is glycated hemoglobin really does not address fluctuation in blood glucose. It just gives you an average number. And now it has been seen that glycemic variability, which actually refers to fluctuation in blood glucose, is actually the increased glycemic variability is associated with an increased risk of hypoglycemia, micro and macrovascular complications, and mortality in patients with diabetes, independent of glycated hemoglobin. So people might have good glycated hemoglobin, but the variability is so much that the rate at which complications happen is much higher. So the use of continuous glucose monitoring device has markedly improved the assessment of glycemic variability in clinical practice and facilitates the assessment of glycemic variability as well as hypoglycemia and hyperglycemia events in patients. So it's very, very important to understand. Now, what happens with glycemic variability? Glycemic variability refers to the swing in blood sugar from the mean level. Okay, and it has been seen that hyperglycemia increases production of reactive oxygen species, which inactivates nitric oxide, leading to endothelial dysfunction and vascular complication. In addition to sustained hyperglycemia, these fluctuating blood glucose actually impact changes in endothelial nitric oxide synthase. And that is why you will find that most of the heart disease or any other vascular complication is much more with glycemic variability. So this is how a CGM report looks like, and there is a target range given depending upon where your patient stands. The center line is the median blood sugar ranges through the day. And then, of course, there is a 25th percentile, 75th percentile, 10th and 90th percentile, which happens, and you can accordingly check your report. Now, this is how typically, I mean, these are few reports which are shown here. So these are typically how reports will look when the patients come to you. So if you see here, above the target range, this indicates above the target range. Above the target range, sugar is at the 80% of the time or more than 80% of the time. This is the first week of CGM when the patient is enrolled. And you will find that a multidisciplinary approach, not only diet, but also exercise, also psychology, because ultimately to follow a diet, you need a lot of psychological fitness. You need to accept the kind of changes which have been given, even though the changes can be a part of your lifestyle or can be given which actually suit your lifestyle. And then you will start seeing that there is a 30% reduction in the improvement in time in range. So there is a 30% reduction in increasing of glycemia, and then there is improvement in time in range. And you will find that these yellow peaks are much smaller as the time goes, and then the patient will start doing better and better. Now, with this, I come to a point where now technology has been used in management of diabetes, because we have monitoring devices which are very technology bound. So moment you have technology bound monitoring devices, you need diets to follow that technology. Otherwise, dietetics is sort of left behind. So digital therapeutics deliver medical interventions directly to the patients using evidence-based, clinically evaluated software to treat, manage, and prevent a broad spectrum of disease or disorder. So technology helps to increase understanding of patients' response to various lifestyle interventions, especially in diabetes. And there is a 360-degree approach to manage diabetes. So what is personalized glycemic response? In our body, normally blood glucose levels are kept tightly between 70 to 140 by various hormones, chiefly insulin. Whenever we eat something, carbohydrates get broken down into glucose in our intestine, and in few minutes blood glucose level rise, and this is known as glycemic response. Glycemic response depends upon amount of carbohydrate, type of carbohydrate, fiber, fat, and sometimes also glucogenic proteins in our diet. But it differs between two people, because we know no two human beings are alike. So this is another digital therapeutics platform from where I've taken these slides. So you'll see that when a person ate certain kinds of food, so look at it, walnut, tea, pistachio, so essentially nuts and one dry fruit, the sugar range, the sugar rise was this person was a pre-diabetic, so sugar rise was much lower. But as opposed to that, the same person as a snack ate Maggi noodles and beetroot juice, although the juice was homemade, which most of our patients, talk about. Look at the glycemic response. It was much higher, and the rise and the variability was much more. Same way, when the person ate toast and scrambled egg, look at the sharp jump and then the sharp drop in the blood sugar. And later on in the night, the same person had a lower blood sugar. So now if you look at the variability is immense, from 67 to about 151, although this person still might have a HbA1c, which is around 7%. So you will realize that this is meal mapping, and it sees blood sugars every couple of minutes after eating a particular food. So when you talk about glycemic index and glycemic load, it measures area under the curve at the point of 2 hours and 1 hour. But with CGM, we know that this can be done every couple of minutes. And this is a classic meal mapping thing where it has been shown that this is a khaman dokla. So these are not great things to eat, or maybe mutia. And you will see that the variability is huge from where it began in 4 minutes to where it has reached, say from 110 to 191, 114 to 177. So this is a huge variability. Okay. But look at other thing. Look at protein supplement. Again, not advocating any supplement here, but just to show that the variability is not there. And in fact, in this person, the sugars went down even after eating a Frankie, which was made from mugata. The sugars actually did not go really up, or in fact, they went down. Now, this is also showing In-person glycemic variability, impact of portion sizes. When we talk about glycemic load, so look at it, aloo paratha, this is the same person. When they ate two medium, as compared to one medium, the variability was very, very different. From 89, it just went to 109, although it was aloo paratha. But from 136, it went to above 100 milligrams, that is 237 with aloo paratha. And just because we emphasize that person should eat protein, this person ate curd with it. And even then the variability was huge. Now this is in-person variation with different cereals. So again, this is in-person variation with a person eating rice, chapati and jawar ka roti. And you will see that variation is actually different with different things. So within this person with rice, it didn't increase, but with other things, it increased more as compared to rice. So like I said, and this rice was regular white rice. This wasn't any specific rice. So what I'm trying to drive the point here is that different people show different kind of variability eating different foods, and therefore sometimes standard prescription don't tend to work. Now again, this is chapati in-person variation with different sources of protein or curries. So curry, mutton and dal. And you will see that here there was tuvar dal eaten, there was aru is colocasia leaves. Uska sabzi was eaten as a form of gravy, and there was mutton curry. And this was all made at home by the patient. And you will see that the variation is very different. Probably aloo ka sabji, the colocasia vegetable, might have jaggery in it. So variation was the greatest. But then other foods also had quite a bit of variation, with mutton curry showing negative variation. So the sugars were actually dropping within the 57 minutes of consumption. This is the first 1 hour. So therefore, probably because gastric emptying delays with eating non-vegetarian food. Now, this is again a different way of seeing patients. So in a pre-diabetic versus somebody who has 20 years of diabetes, you will see that variation is different. Obviously, this person is taking OHA, and in this case is in this case is taking a sulfonyl urea. So you will see that the rise is much lower as compared to a pre-diabetes person where the rise is much greater. This is again interpersonal variation. In one person there is with wheat, that is roti, and in other person it is with jawar ki roti. And you will see that in this person jawar ki roti worked better than wheat ka roti, whereas this person, even wheat ka roti caused a basic slight response in blood glucose. So the guideline for personalized nutrition is define the potential users and beneficiaries, validate diagnostic methods and measures, maintain quality data and relevance, derive data-driven recommendations from validated models and algorithm, provide rigorous scientific evidence for effect on health or function, deliver user-friendly tools for healthy individuals, align population based on recommendation, and so on and so forth. So it's very important that personalized glycemic response with the coming in technology of CGM be used in day-to-day practice. So in conclusion, current diabetes plans are based on one size that fits all. When I mean one size that fits all is recommendation wise. So say there are certain standard guidelines given for say choosing foods based on glycemic index or load, but we find that in clinical practice, this does not hold true for most of our patients. Even though in some patients we try to give low glycemic index food, the glycemic response, especially in the first hour, is very high. And therefore, we need to rethink and relook at the whole thing. PGR, that is personalized glycemic response based on base plans, can help you to know real data on how your body works. Visual indications to the patient about which foods raise their blood glucose, and therefore if the patient is using CGM, and which most of our patients tend to use in today's day and age, you will find that it will work. It's a 80-20 rule. The moment you decrease the portion size of the food with high PGR, your time and range improves. And this is, and for this, focus on top 5 PGR foods is important. Personalized glycemic plans are based on your personalized glycemic response. Understand which are the top 10 unhealthy foods for you, even though they are, so-called diabetes friendly. Which are top 10 good foods for you? What happens to you in sleep? This is a very, very big problem. Nocturnal hypoglycemia unawareness, and sometimes nocturnal hypoglycemia leading to a hyperglycemic reaction in the morning is very, very common among older diabetes patients with longer duration of diabetes. Also very, very common among individuals with type 1 diabetes. So in that case, personalized glycemic response will help a lot. And what happens in exercise, and which exercise is best for you. In type 1 diabetes, we find more often than not, our kids, when they go out to play, they come back with higher blood sugars. And then their parents get very frustrated that even though our kids exercise or play, their blood sugars still are not in control, or they rather increase. And this kind of technology will also help you to decipher what kind of exercise, what duration of exercise is good enough for the child or for the adult, for that matter, somebody going to gym, how is it going to work, and will that personalized glycemic response help them? Thank you so much for patient hearing, and I'll be happy to take in any questions that you will have.